The Centers for Medicare and Medicaid Services Center for Clinical Standards and Quality brings you CMS QI Voices. As part of this series, CMS is hosting several special episodes to provide nursing homes with the facts needed to discuss care plans with residents and families in order to improve resident outcomes related to the COVID-19 virus. In conversations with the CMS Chief Medical Officer, nursing home leaders will hear about the latest information on COVID-19 vaccines and therapeutics from CDC and FDA experts. Let's listen in.
Welcome to our second special edition. I'm Dr. Lee Fleischer, Chief Medical Officer and Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. The purpose of this audio series is to provide our nation's nursing homes with clear, actionable messaging about the most impactful interventions to increase vaccination rates and reduce mortality from COVID-19 in nursing homes. Today, I'm joined by Dr. John Farley from the Food and Drug Administration and Dr. Meg Sullivan at the Administration for Strategic Preparedness and Response, or ASPR. Dr. Farley is the Director of the Office of Infectious Disease in the Office of New Drugs at CDER. His office is responsible for the review of new antiviral and antibacterial drugs and engage in the agency COVID-19 response focused on development of monoclonal antibody and small molecule therapeutics. Dr. Meg Sullivan is the Chief Medical Officer for the Administration for Strategic Preparedness and Response at the U.S. Department of Health and Human Services. ASPR leads the nation's medical and public health preparedness for, response to, and recovery from disasters and public health emergencies. John and Meg, welcome. Thank you for joining me. We know how important vaccines are and have another module discussing vaccines with Dr. Peter Marks. But treatment for those who have not received the vaccine or contracted COVID after the vaccine is so important. Why are we concerned about our seniors and risk for hospitalization death if they develop COVID-19?
Thank you so much for that question. And I will just say that we know that age remains the strongest risk factor for severe COVID-19 outcomes, with the risk of severe outcomes increasing markedly as age increases. And seniors, unfortunately, continue to have the highest risk of being hospitalized and dying because of COVID-19. Over the past 2 months, nearly 90% of COVID-19 deaths nationwide have occurred in individuals age 65 and older, with 70% occurring among those age 75 and older. And we know that people living in congregate care settings are also at high risk, as 1 in 5 recent COVID-19 deaths were in nursing homes and other long-term care facilities, such as assisted living facilities. We also know that this toll is heartbreaking and unacceptable, particularly as we now have updated COVID-19 vaccines and treatments that can, along with other strategies such as improving indoor air quality, help prevent COVID-19 deaths. In a recent CDC study, most people eligible for ritonavir-boosted nirmatrelvir, which is a Paxlovid, or a treatment we will be talking about today of COVID-19, in every age group, including those ages older than 65, did not receive a prescription for this medication. We know that residents of long-term care facilities are nearly all at risk for severe COVID-19 outcomes and eligible for treatment. Recent data does encouragingly suggest that the highest utilization rates of COVID-19 treatments are long-term care facilities, but there are still many eligible residents not receiving these potentially life-saving treatments. And we know every facility can act to ensure its community of residents is aware of COVID-19 treatments and their effectiveness, and to promote easy access to these life-saving medications.
You just mentioned Paxlovid, but what other treatment options, including Paxlovid, are available to someone in a nursing home who is diagnosed with COVID-19?
Thanks, Lee, for that question. So as Meg mentioned, early outpatient treatment of mild to moderate COVID-19 with a preferred therapy, and the 2 preferred therapies are ritonavir-boosted nirmatrelvir, which we'll all refer to during this podcast as by its trade name Paxlovid, or remdesivir, which we'll refer to by its trade name Veklury. We also have an alternative therapy, molnupiravir, which we'll refer to as Lagevrio, its trade name. They've all been shown to prevent hospitalization and death in clinical trials. Paxlovid and Lagevrio are oral treatment options administered for 5 days. Veklury is given by infusion with 3 daily treatments for outpatients.
So, what are the benefits of these treatments? What data do we have from the clinical trials?
That is such an important question. And you know that each of these treatments that Dr. Farley just mentioned were administered to patients with mild to moderate COVID-19 with risk factors for disease progression in clinical trials and were shown to reduce the risk of hospitalization and death. I also do want to talk briefly about the increasing amount of real-world evidence, including specifically according to a recent CDC study that examined hospitalization rates among US adults eligible for COVID-19 treatment with Paxlovid who were diagnosed with COVID during April to August of 2022. People who were prescribed Paxlovid within 5 days of diagnosis had a 51% lower hospitalization rate within the 30 days following diagnosis than those who were not prescribed this medication. People who were previously infected with SARS-CoV-2 and those who had received 3 or more COVID-19 vaccinations also benefited from Paxlovid. Other studies have also reported a 45% to 89% reduction in emergency department visits, hospitalizations, and deaths due to COVID-19 among patients prescribed Paxlovid. Again, this is just one example, and Dr. Farley also mentioned the 2 other options, Veklury and Lagevrio, both of which have evidence of being safe and effective. And just by ending, the recent increases in cases and hospitalization rates highlight the importance of preventing severe illness through the use of prevention measures and therapeutics.
Thanks so much. That really highlights the importance that we all believe in this particular population that is so high risk in the nursing home. So I've heard a lot of clinicians are nervous about prescribing these treatments. Who should be concerned and why? Are there particular disease states that the residents might have? Are there different treatments with respect to contraindications? I wonder if you could speak to some of these scenarios, and I know that we'll be producing some materials to make it easier to have these at your fingertips, but thank you.
Thanks, Lee. And I think that's another very important question. I think in the long-term care setting, the healthcare team really, it is doable to implement access to these therapeutics. But for each of the therapeutics, it's important to review the patient's medical history to determine what would be the best choice for them. A key piece of information is the patient's renal function or kidney function. And we have this information for most of our long-term care residents. A lower dose of Paxlovid is needed for patients with a glomerular filtration rate between 30 and 60. And note the glomerular filtration rate is usually calculated from the patient's last creatinine laboratory measurement. And there's a special dose pack for patients with a glomerular filtration rate between 30 and 60 that the pharmacist will be able to dispense. We do not have good data for dosing patients with Paxlovid who have a glomerular filtration rate under 30. So that's severe renal compromise. And these patients should not receive Veklury either due to an issue with an inactive ingredient in Veklury. So another key piece of information is to review all the medications the patient is currently taking. Paxlovid is a strong inhibitor of an enzyme called CYP3A, and there can be clinically significant drug interactions. However, many of these potential interactions can be managed by holding the other drug for the 5 days of Paxlovid treatment, or in some cases, modifying the dose of the other drug. And there are tools to help healthcare providers determine the right plan for their patient. Examples include the NIH COVID-19 treatment guideline web pages, the Liverpool COVID-19 drug interactions website, and the FDA fact sheet and checklist. In a long-term care facility, healthcare providers should review each patient's history and have a COVID-19 treatment plan for each patient in advance. This will serve providers well to have this in advance of an outbreak on the unit when there will be many competing priorities.
What are some of the common side effects of these treatments? We've heard about rebound cases. What are they, and what is most important to know about rebound?
Again, another important question. And first, like most medications, a small number of hypersensitivity reactions have been reported. And we'll note that, especially for Veklury, a short period of observation is needed after the infusion. In general, the medications are generally well tolerated. And some, but not all people who take antivirals for COVID do have temporary side effects, with the most common side effects including nausea and vomiting, diarrhea, myalgias or muscle aches, dizziness, and an altered sense of taste. Specifically for rebound, which is defined as experiencing recurrence of symptoms and/or SARS-CoV-2 antigen positivity after initial resolution, it's important to note that it has been observed not only among patients treated with these COVID-19 medications, but also occurs in patients receiving no treatment. In addition, recent studies suggest patients experiencing rebound have an extremely low probability of developing severe COVID-19, and further studies on this phenomenon are ongoing. I will just emphasize that concern about recurrence of symptoms after treatment should not prevent treatment for those at risk for severe disease, hospitalization, and death.
It's already been mentioned some of the resources available for clinicians to learn more and speak with others with regard to these treatments. Are there additional resources that you suggest people should look at or listen to?
Yeah, thank you so much for asking that question. And I can say that there are many resources available to help clinicians feel comfortable providing treatment. As a couple of examples, ASPR holds weekly meetings with stakeholders on all COVID-19 treatment updates, including the latest variant numbers, the impact to the treatment portfolio, and any changes from the FDA, as well as weekly office hours with stakeholders for specific questions. ASPR also holds current biweekly clinical round calls focused on COVID-19 treatment. In addition, the ASPR website, or aspr.hhs.gov, has a number of clinical resources and decision aids that we will continue to disseminate widely. In addition, we will be developing an information sheet specific for long-term care facilities about these safe, effective treatments in the very near future. I will also note that December 20th, the CDC released a health advisory network entitled Important Updates on COVID-19 Therapeutics for Treatment and Prevention, which includes incredibly important information and many additional resources and links. I think I also just want to echo what Dr. Farley said about the importance of healthcare providers proactively counseling high-risk patients about the availability of effective treatments and discussing a COVID-19 action plan with their patients. This care plan should include prompt testing at the onset of COVID-19 symptoms and rapid access to antivirals if SARS-CoV-2 infection is detected. In particular, long-term care facility clinicians should also work with pharmacy partners to ensure facilities have adequate supply of oral antiviral stock to minimize treatment delays and ensure patients initiate treatment within 5 days of symptoms. Long-term care facilities should also ensure timely access to effective COVID-19 treatments for all eligible patients, including through pre-positioning the medication directly at the facilities.
So I'm going to ask you a bottom line question. We at the Department of Health and Human Services over the last several years have seen how vulnerable this population in nursing homes are to this disease once contracted. Bottom line, all or virtually all patients in nursing homes who contract COVID-19, and I'll leave the end of the sentence to John, you, and Meg. How would you end that sentence?
I can start. I think I would end this sentence with should have a treatment plan in advance that the facility can implement quickly.
And Meg?
And I think first I would just echo what Dr. Farley said and how important that is. I would also add, should be up to date on their most recent COVID vaccines because we know how important that is. And again, have that plan in place for timely access to testing at the development of symptoms, as well as timely access to treatments that could potentially be life-saving.
Thank you for joining us today. Please join us next time to learn more to help you increase vaccination rates and reduce mortality in nursing homes.
To learn more about today's episode and to access all of the CMS QI Voices audio series and show notes, please visit qioprogram.org/CMS QI Voices. Thank you for listening to CMS QI Voices.